All right, let's dive into a classic endocrine challenge, one that every medical trainee really needs to master: Arginine Vasopressin deficiency. You might know it by its old name, central diabetes insipidus. Now, it can seem pretty intimidating at first, but with the right framework, you're going to feel confident diagnosing and managing it. So picture this. You're on your neurosurgery rotation and you get a call about a post-op patient. They're making tons of urine. We're talking liters and liters, and they absolutely cannot get enough to drink. What is going on here? This isn't just a textbook question. This is a real deal scenario you are going to see. That sudden, dramatic onset, that's your first huge clue. So these are the big four, the absolute hallmarks you've got to recognize. First, polyuria. And we're not talking about just peeing a little more than usual. The definition is an output greater than 50 milliliters per kilogram in 24 hours. That's a ton of urine. Then there's polydipsia, this intense, relentless thirst as the body is desperately trying to keep up. And here's the kicker. Despite all this water loss, which should be concentrating the blood and driving the sodium up, the urine stays, well, super dilute. It's this fundamental mismatch that is the absolute key to the whole puzzle. Okay, so we see the signs, but what's actually going on under the hood? Let's peel back the layers and look at the physiology behind this whole dramatic picture. Really understanding the why is what's going to make the diagnosis click. So what it really boils down to is this: the body's main water balancing hormone has just stopped working. AVP, or antidiuretic hormone, is basically the signal that tells your kidneys, hey, hold on to water. Without that signal, the kidneys just open the floodgates, and all that water flows right on through, leading to these massive, massive fluid losses. Now, this is super interesting because it shows you the physical journey of this hormone. AVP isn't actually made in the pituitary. It's synthesized way up in the hypothalamus, then it travels down these long neurons through the pituitary stalk and is stored and released from the posterior pituitary. So you can imagine any damage anywhere along that entire route can totally shut down the release of AVP. And that path we just talked about, that's exactly why this list of causes makes so much sense. A lot of them are structural things. That post-neurosurgery patient from the beginning, classic example. Head trauma, tumors like a craniopharyngioma, or even cancer that has spread from the breast or lung can physically mess up that AVP pathway. Of course, you can also have infiltrative diseases like sarcoidosis or inflammatory conditions in the mix too. Okay, so you're on the wards, you see the crazy urine output, the sodium is starting to creep up, and you're thinking, this has got to be ADP deficiency. Your clinical suspicion is high. But how do you prove it? How do you lock in that diagnosis? Let's walk through it. This quote really hits the nail on the head. It gets right to the core of it. Think about it. Your patient's blood is getting more and more concentrated. The serum osmolarity is high, the sodium is high. Normally, that should be a 5-alarm fire for the kidneys to conserve every last drop of water. But in this case, the kidneys don't get the message. The urine just stays dilute. That paradox, that mismatch, that's your diagnosis right there. Now, a lot of the time, that clinical picture is crystal clear. But what about the tricky cases? Maybe it's a partial deficiency or something else is muddying the waters. You need a formal test to be absolutely certain. So what's the gold standard you're going to order? It's the water deprivation test. This is the classic, definitive way to figure this out. Basically, you carefully restrict the patient's fluid intake to see if their body can respond properly to dehydration. And you have to monitor them very closely, checking labs, weighing them. The goal is to get their plasma concentrated enough, usually over 295 milliosmoles per kilogram, to see what the kidneys do under that stress. And here it is. This is the moment of truth. As that plasma osmolality climbs past 295, a healthy person's urine osmolality would skyrocket, way up over 800. Their body would be desperately trying to save water. But in our patient with AVP deficiency, nope. The urine osmolality just stays stubbornly low. The kidney never got the signal. And that is your proof. But wait, we're not done. There's one last crucial step. After you've proven the body can't concentrate urine on its own, you give a dose of desmopressin. That's just synthetic AVP. Now, if the urine osmolality suddenly shoots up, bam, you've confirmed central AVP deficiency. It means the pituitary wasn't making the hormone, but the kidneys work just fine. If nothing happens, well, then the problem is with the kidneys, something we call nephrogenic AVP resistance. It's a brilliant way to pinpoint where the problem is. Amazing. You've worked through the whole thing, from the initial signs to nailing the diagnosis. So, now what? What's the plan? How do we actually manage this condition? The good news is the treatment makes perfect sense. The hormone is missing, right? So we replace it. We use that same synthetic AVP, desmopressin, as a replacement therapy. It's really that logical. But, and this is a huge but, it's not as simple as just writing a prescription. This is a real balancing act. On one hand, you want to relieve those awful symptoms, like waking up all night to use the bathroom, and just let the patient live a normal life. But on the other hand, if you give too much desmopressin, they can't get rid of free water, and that puts them at serious risk for dangerously low sodium or hyponatremia. So, here are your pro tips for getting this right. 1. Start low and go slow with the dose. Always. 2. For many patients, a single dose at bedtime is a total game changer. It's all they need to sleep through the night. And 3, and this is maybe the most important part, you have to teach your patient to trust their thirst again. They need to drink when they're thirsty, not just out of habit or on a schedule. So let's bring it all home. What's the big takeaway? At its core, it's a simple replacement therapy. The hormone is missing, so you replace it with desmopressin. But as we've seen, it's a therapy that requires really thoughtful, careful management and fantastic patient education to get it right. Look, AVP deficiency can seem really scary at first, with these huge dramatic symptoms, but it doesn't have to be. By understanding the why, recognizing the classic signs, and knowing the steps for diagnosis and treatment, you've got a rock-solid framework. And that framework is what will give you the confidence to tackle these cases systematically, from that first phone call all the way to successful long-term management. You've got this.